Okay, hi guys. I hope you're all doing really well. So today we'll be doing affective disorders. That's depression and bipolar. Thing is, I've realized quite recently, whilst making these slides, that depression is really big and also really important for you guys. So I think we'll focus on depression. If we don't have time for bipolar, then I think what we'll do is we will try and do bipolar in the next session, because that's also a very big diagnosis, and things like anxiety disorders and personality disorders and eating disorders we can do in the next term. So to start off with, got a bit of an SBA. This SBA is not to do with the affective disorders. It's a bit of a recap from the last session on psychiatry that I did 4 weeks ago, which is on the Mental Health Act. Even if you weren't there, good revision for that, and we'll do a very brief recap of the Mental Health Act. But question goes like this. So I've turned off my camera instead of skipping. So you've got this man, he's Jason Peters, and he's a 22-year-old man, and he's been brought into the emergency department by ambulance because he suddenly lost consciousness. In the ambulance, they found that he had VTAC. It was pulsed though, so they didn't shock him. He regained consciousness in the ambulance. When he came in, he was really hypokalemic. ED stabilized him, and they want to admit him. They want to admit him for refeeding. I forgot to put the really important part of this question. He has a diagnosis of anorexia. He's got an established diagnosis of anorexia, which should have been right at the start. So I'll include that in the slides that we put up. Basically, they want to admit him. He understand that, and they've bleeped you. You're the F2 for liaison psych, and you see on his records this is actually the third time he's come to ED with this sort of thing. So it's not the first time, and previously he's been detained under Section 3 of the Mental Health Act. So I want you to decide which of the following statements is true. So you've got A, which is, as an F2 doctor, you're not in a position to detain Jason, and you need to bleep your registrar in order for him to detain, or him or her to detain Jason. Because Jason's presented with a physical problem, he can't be detained under the Mental Health Act, and the Mental Capacity Act is more appropriate. C is you can detain him under a 5.2, but then he can be admitted onto the medical ward and treated there. 4D is after a formal Mental Health Act assessment, he can go straight to a Section 3, and E is a patient detained under the Mental Health Act has to be admitted onto a psychiatric ward. They cannot be on a medical or surgical ward. So I'll give you guys about 30 seconds for that. It would be nice if I knew how to make a poll on these things, but oh yeah, Anush, how do I make a poll on this if I can?
I think they disabled it for some reason. Like they got rid of it. It's fine. Write down an answer on the piece of paper.
Write down an answer on a piece of paper, and then just hold it in your heads or on the piece of paper, and we'll go through it in another 15.
Also, I don't know, Ahmed, would you agree? But I think this is the most complex bit of the Mental Health Act.
Absolutely. Yeah, I've made this question deliberately hard. So, Mental Health Act questions are usually significantly more straightforward than this. This one is really stretching it. It's got Section 3, it's got 5.2 in it, it's got conflict with the Capacity Act. Basically, eating disorders of the Mental Health Act are if they want to be really mean to you. So I've deliberately given you the meanest thing, because everything else they give will be less mean than this, and you'll be fine with it.
Yeah.
Right.
Like, there's literally no way you can make the Mental Health Act harder than this question. This is the absolute hardest question you can get.
Right. Okay, so let's go through these. So the right answer is D. Can someone tell me why A is wrong? Why is A the incorrect answer? Well, by the way, all the explanations are in the notes on this slide. Perfect, Christy. You can use a 5.2, and the reasoning for that is to use a 5.2, you just have to be a fully GMC qualified doctor. The only person who can't use a 5.2 is an F1 because they're on provisional registration. Once you hit F2, you can use a Section 5.2, which is probably an easy way to remember it. Both have got T in them. B. And this is, again, one of the hardest parts of the Mental Health Act. This point here is a big stumbling block. Perfect. So Eleanor's got it right on. If something is directly secondary to the mental illness, the established psychiatric diagnosis, you can use the Mental Health Act. If this was, say, and this is describing an actual legal case, which set the precedent for this, a man with schizophrenia who, whilst acutely psychotic, also has a gangrenous foot and is refusing amputation, you cannot deny him you cannot amputate against his will just because he has schizophrenia. The two have got nothing with each other. That, for the leg, you'd need to do a capacity assessment. However, in this case, which is hypokalemia secondary to anorexia, which is a lethal complication and unfortunately not an uncommon one, that's a direct consequence. So the Mental Health Act can be warranted here. Can someone tell me why C is incorrect? Is there anything F1s can use? Unfortunately, we can't. Yeah, we have to refer to our seniors. In terms of detaining a patient, we can't do that. You'd have to call your SHO to be like, "Hi, can you like 5-2 this patient?" The nurse could 5-4 them, but that almost never happens. You basically get your SHO to do it. Something that you might be able to do is F1. Is the so I'll get to tap on something in a second. Something that you might be able to do, start filling out the paperwork or the document and get the SHO to sign it, and they might appreciate you for that. But the actual signature has to be an F2 or above. So Telephone says a 5-2 must be used on inpatients. So let's say the problem with this one is isn't necessarily that of his patient status. So once they are, technically, when a patient has gone into ED, in the eyes of the Mental Health Act, they've basically been admitted. So the 5-2 isn't a problem because of where he is. He's also being admitted, so he can be because of that. The problem is with treatment. So the one thing I want you to remember about the Mental Health Act, and I did talk a lot about this on the last session, is unless it's a 2 or a 3, you cannot treat a patient against their will. Only under a Section 2, which is your 28-day holding an assessment order, or a Section 3, which is your 6-month treatment order, can you treat a patient against their will. The 5-2, you can't do it. 136 or the 135, which are the police orders, can't do it. Section 4, which is weird, you'll never really hear of, but is very uncommonly used in the community, you can't do it. All of the other orders are in order to keep the patient in one place whilst you do a formal assessment to see if they need to be detained under a 2 or a 3. So only a 2 or a 3, you can treat the patient there. So you can detain the patient, then you can't start the refeeding until you get the psychiatrist, 2 psychiatrists, and an approved mental health practitioner to come see the patient and go, yep, they need to be detained under the Mental Health Act. Now you can start refeeding against their will. D is correct. The reasoning for this is you can go straight to if the patient is presenting in the exact or almost similar manner to a previous time where they've been under Section 3, and there's no suspicion that something different is going on here, then you can put them back onto a 3 again. The reason is the Section 3 is a treatment order. The Section 2 is just an assessment order. You don't need to reassess this patient. You basically know what's going on. And E is incorrect. I won't ask you why that's incorrect. It is just incorrect. And I'm sure all of you in 4th year, when you're on your Gen Med and Gen Surg placements, and even this year, will have come across patients, you look in the notes and it will say that they are under the Mental Health Act, under a Section 2 or a 3, but they've been transferred because they've developed a physical problem. Maybe they've had a chest infection that's needed intravenous antibiotics. Maybe they've had appendicitis, seen that happen once or twice. You will often notice these patients because there'll be somebody sat next to their bedside and you might wonder who is that patient. And the patient's usually the mental health nurse who's keeping an eye on them. Often there's also security at the outside of the bay, but you absolutely have a section on one of these wards. So a medical or surgical or intensive care ward, and as soon as they get better, then they will go back to the mental health facility to psychiatric inpatients. But in the interim, then they will be on a ward, and that's completely fine. Any questions about that? And if there are, put them in the thing and we will answer them as we go. Right. So now we actually start talking about depression. So whatever you go into, you're going to see depressed patients there's a good chance, well, practically all of you, I'm almost certain, will know somebody who's had a depressive episode. Some of you will have had them themselves. Some of you will have had, friends or loved ones. Oh yeah, just to answer that, you can use a 5.2 in ED. Basically, for the intention of the Mental Health Act, a patient in ED is admitted. It may not be the case in terms of hospital bureaucracy, the whole 4-hour rule, they can't be in ED for more than 4 hours, they're not technically admitted. Under the Mental Health Act, if they are in hospital and they're in ED, you can now use a 5.2 on them. So it's incredibly common, and the important thing about depression, the reason why you will see it whatever you go into, not necessarily just because a patient you're having has depression, but I mean, as in a first presentation, is it can present first anyway. You could be the GP who a patient first comes to complain about it. You might be the ED doctor after somebody's made a serious attempt on their life. You might be the psychiatric doctor who goes to see somebody who's been taken to a place of safety by the police because they found them at a railway station where they were about to try to take their own life. You can find it anywhere. And even though it's most commonly managed in the community, you will see it in practically every setting, ICU included, that sort of thing. Sort of estimates for your prevalence and incidence are hugely variable. Some people say 10%, in the community, higher. Thing is, it varies in populations. For example, the prison population is significantly higher, about 30 to 40%. It varies when you look at males versus females, different ethnicities, different occupations, socioeconomic classes. You can't use it in ED. Okay, I'll have a look at that. I'll have a look at that afterwards and get back to you on that, because I was pretty sure that you could use it in ED. But sorry if I'm wrong about that. I will have a look at that just afterwards, and if I am wrong, I will correct myself. No, that's okay. No, that's really, really important, because I'm almost certain that you can use a 5.2 in ED. But if I'm wrong, then that's really important. I only change the slides and everything, so thank you for pointing that out. Right. So point is, we're probably underdiagnosing major depression. It's really, really important because it's the 4th biggest cause of morbidity in the world, according to the World Health Organization, and it, for lack of better terms, really, really sucks. What causes depression? Anything, really. There's no single factor. It's not like something like type 1 diabetes, where you can go destruction of the beta cells in the islets of Langerhans. Any sufficient psychological trauma, social upheaval, somebody being divorced, losing their job, a traumatic event like a loss of a loved one, or even sometimes we've got no idea psychologically or socially, there's no trigger there, and it might just be something, we think it might just be biological. We don't really know what the cause of depression is. It could basically be practically everything. And that really explains why there's such a huge range of risk factors. So with things like depression, risk factors range all the way from family history, which implies, some sort of biological link. If you have a chronic illness, any chronic illness raises your risk of depression and anxiety, anything. That's going from your lupus to your heart failure to lung fibrosis, COPD, any long-term health condition that's going to make your life more sucky and harder to do things that you normally can do is more likely to make you depressed. Makes sense. So that's a slide. Oh, ignore that empty slide. That's a slide that we've just talked about. So let's talk about signs and symptoms. Mainly symptoms. So how are we typically taught how to divide the symptoms of depression? Is there any approach that people mention? Okay, perfect. Core symptoms. So core symptom, yeah, brilliant. I like this. Biological symptoms. Yeah, so the ICD-10 sets out its sort of core symptoms. And a common thing that we're taught is going on lines that Minusha has said. So you've got biological symptoms, and you've also got symptoms that split into psychological symptoms and social symptoms as well. So let's talk a bit about biological symptoms. What are examples of biological symptoms of depression? So that's a risk factor and a potential when you're thinking of causes, but we're talking symptoms, so what might the patient come in with? Really good. Okay, so you've got sleep disturbance. And by the way, when we see sleep disturbance, it doesn't necessarily mean that they can't sleep. It could be patients who sleep too much. It can be patients who can't sleep. It can be patients who fall asleep but then wake up at 2 o'clock in the morning. So that's called early morning waking, which is actually very specific for depression. Patients with come to you saying, you know what, I fall asleep fine, but I wake up at 2 in the morning and I can't get back to sleep. Early morning awakening, thank you. Pardon me. Anhedonia is classified more as a psychological symptom. So anhedonia, somebody define anhedonia for me, please. Sort of a fancy word for what is actually quite a sad thing. Yeah, loss of interest in things, but most importantly, loss of interest in the things that a patients previously found enjoyable. So not just generally loss of interest, but let's say the person really enjoyed playing football or really enjoyed crochet or going on runs, and now they just don't have the interest in that anymore, which is really quite devastating. The thing that you love doing now just doesn't give you anything. It's really quite upsetting. So anhedonia is a psychological symptom. We've mentioned a few of the key biological symptoms. And then you've got your social symptoms. Your social symptoms, as you would expect, are the things that deal with your relation with other people. So social withdrawal is really common. Patients will find it difficult to interact with other people because of their low mood. So you'll find that they don't talk to people as much, their friends, and they'll withdraw from social situations, which can be detrimental in itself. People can become more irritable or agitated. People snap easier, and anger may not be something you associate with depression, but it might appear on the surface that, wow, this person's gotten a lot angrier than usual and I don't really know why. And that's a social symptom. Or just difficulty to sort of cope with your day-to-day activities. So if we're talking a bit more about some of the biological symptoms, sleep's a really important one that you guys have mentioned. Anergia, which is the fancy word for sort of a loss of energy and drive, so that's your fatigue. Appetite can go both ways as well. Some people completely lose their appetite and lose a hell of a lot of weight. I've seen patients who've lost several stones over the course of their depressive episode, and have gone from a fairly healthy BMI to 18, 17, a quite dramatic sort of weight loss because of how little they eat. But then you've got, on the other hand, people who find that they overeat when they're depressed. It's, for some people, it's a coping mechanism. For others, it just becomes a sort of symptom. Additionally, their weight might go up because of lack of activity. If you're eating as normal, but you're not doing as much, then your weight will go up. So patients may complain of changes in weight. And then libido is a really, really big one. I think a lot of people underestimate how much problems in people's sex lives will affect them and how big of a problem it is. And it's the reason why, for any of you guys who've done, who will be doing urology this year, when you talk to people about things like, for example, in men, erectile dysfunction and other forms of sexual dysfunction, a really important thing to screen for is how is their mood doing? Are they anxious? Are they low? Are they stressed? Because you might go in thinking this is something organic. Oh my God, have they got diabetic neuropathy and they're no longer able to have an erection? And actually, they're just really depressed, and their libido's completely of it, and they've only come to the doctor because it's now starting to affect their relationship with their partner, and they've come in saying, look, I don't get erections anymore. And you figure out, oh wait, hang on, also sounds like you're not doing too hot elsewhere, that things sound like they're not going too great in general, you've lost your job, that sort of thing. Psychological symptoms, so anhedonia was mentioned. You've also got your things like your feelings of hopelessness, guilt, worthlessness, which become very common and obviously very distressing. If that's what's going through your head nearly all of the day, most days, that's just cycling down even more and making you feel even worse. Thoughts, that's not supposed to just say thoughts, but it's supposed to say thoughts regarding self-harm or suicide. I remember there's sort of a staggering of that. So if somebody's thinking about self-harming, and says, you know what, sometimes I think about hurting myself, but I wouldn't do it. or I don't really go through with it, or sometimes I think about ending my life, but it comes and goes. That's sort of your lowest level of risk. You'd call that suicidal ideation in the case of suicide. But then the next step up, which is a bit more worrying, is when somebody goes, I've thought about it and I've got an idea of how I might do it. Same thing with self-harm. Like sometimes I've thought about picking up a knife and just, slashing at my arms. I haven't done it yet, but I think about it. Or if someone says, sometimes I go to my car and I sit in the car park of the train station. I just think about throwing myself in front of a train, but I don't do it. Then that's usually even more worrying. And then you got to the point where either with self-harm, they actually do it, which is your highest level of risk to self, or they've attempted suicide before, or now they actively have a plan. And we'll talk about self-harm and suicide at a later date, because again, they're a big topic to do with risk assessment, which is your most important part of psychiatry. But if someone's gotten to the point where they have a plan and all that's left is for them to sort of go through with it, that's your highest level of risk assessment. Suicide obviously is the most worrying thing. Self-harm's not great either, because remember, a significant fraction of suicides are unintentional, where a person was self-harming but then went further than they intended, so cut deeper than they thought they would and bled significantly. So self-harm is still a worrying thing. Abnormal ideation, like psychotic depression, which does happen and is not uncommon, is another psychological symptom. I've put Cotard's phenomenon, which is an SBA favorite. What is Cotard's phenomenon? Yeah, so it's when a patient feels that a part of their body has died, or that they have died. Things like, my heart doesn't work anymore. I've turned to stone on the inside. I'm not alive anymore. It's a really intense delusion. Why is that worrying? What might happen if a patient thinks they're dead? Yeah, self-neglect, exactly. People will think, and they're right in thinking so, that the most likely cause of death secondary to depression is through suicide, through a person taking their own life. But in severe depression, that's also how people might die. Completely dehydrated, have stopped drinking, or haven't eaten for weeks. And that does happen. If you think you're dead, what is the point of carrying on with eating and things like that? So self-neglect, as the two of you have pointed out, is a really, really big thing. So these are your symptoms. Now, somebody earlier mentioned core symptoms, and this is, for clarity, it gets confusing with the two sort of diagnostic manuals out there. You've got the DSM, you've got the ICD. Been asked about it before. I think somebody messaged me about it. To make it clear, what we use in this country for diagnosis is the ICD, so that's the World Health Organization's diagnostics manual. America uses the DSM, so that's by the American Psychiatric Association. Over here, the only time we'd really use the DSM is in terms of research, so academic work, because it's nice to sort of unify things across America and the UK and Europe. But for diagnosis, we use the ICD. So according to the ICD, what are the core symptoms of depression? Perfect. So low mood, anhedonia, loss of energy. Those are your core symptoms. If you're struggling to remember them, I use the acronym LAF, as in it sounds a bit like laugh. So loss of energy, low mood, anhedonia, and fatigue. It's a stupid acronym, but the idea being that, you don't laugh as much if you're depressed. It's a horrible acronym, but it helps some people. Right. So these are your symptoms. In terms of the diagnostic criteria for depression and classifying episodes, honestly, might be worth learning for exams, where they might ask you, how would you classify this episode? As far as I'm concerned, it's not actually that useful. Usually by talking to a patient, you'll be able to say, they're a bit depressed, as in they qualify for as having a depressive episode, but they're able to function to, wow, this is really getting in the way of things, to, okay, I'm really worried about this person. Technically, and this is entirely arbitrary, a group of people sat down and decided this is how long you need to have symptoms for in order for it to be called a depressive episode. How long must symptoms persist before you can say that somebody has a depressive episode? What is the shortest period of time you can have symptoms for and it be called depression rather than just, yeah, perfect, 2 weeks. So, entirely arbitrary thing. There is no particular reason other than some people decided, well, 2 weeks is a long enough period of time for us to think this isn't just a transient thing. This is something that's been carrying on. So, in terms of diagnosis, we've talked about the core symptoms, and then we've said you need to have at least 2 of the core symptoms, most days for at least 2 weeks. The associated symptoms we talked about on the previous slide. So we've talked about disturbed sleep, concentration, low self-confidence we didn't mention, but appetite changes. Some people you might notice start speaking a lot slower or find it harder to, start moving a lot slower. And it's usually other people who notice that, which is why in sort of the diagnostic screening, it's, has anybody told you that you are speaking slower than you usually do? Old school term for that is psychomotor retardation, but nobody really uses that anymore. You just say that people are, speaking slowly. Another thing is people might just become more agitated actually and start speaking faster. And remember, depression is often comorbid with anxiety. Guilt and self-blame is also really common, and then you've got your suicidal thoughts. The stratification system, which again, I really don't think is worth remembering maybe the day before SBAs, is if they've got 2 core symptoms, that qualifies them for mild depression. You can have another symptom, it's still mild depression. But my way of looking at it is if the patient's upset, but they're still able to continue with most of their activities, then it's mild depression. Moderate depression, so they still need the 2 core symptoms, but then it's another 2 to 4 of the other symptoms, so of these ones. Or in my approach, the patient is having difficulty now. It's starting to affect work, it's starting to affect their relationships, it's really getting in the way of things. And do remember, people can compensate, if that's the best word, for depression, in that people who, you might hear the phrase, it's definitely not medical, but you might hear it sort of around on social media of high functioning depression, which really is just that certain people are able to, are depressed, but still from the outside look like they're doing perfectly fine, coping with their jobs, that sort of thing. So this whole thing of, well, if the patient's functioning, then they're probably doing fine, doesn't necessarily hold up. There are some people who are severely suicidally depressed, but still turn up to work each day and give off this impression that everything is fine, so it doesn't necessarily hold up. You've got your severe depression. The important thing with severe depression, if they're psychotic symptoms, they're severely depressed. No ifs, no buts. That's automatically the episode of severe depression with psychotic symptoms. Severe depression, usually if they're actively suicidal, and I don't mean they're thinking maybe about taking their life, but it's transient, but as in they've made a plan and that sort of thing, that's severe depression, and that's really, really very worrying. An important thing with any mental health presentation is excluding organic causes. Same applies to depression. So what are some organic causes of what looks like a low mood that we might need to exclude before we can start saying, well, this person's got a primary mental illness, they've got depression? What other things can cause a low mood but aren't, well, depression? They're secondary to something else. Hypothyroidism is the biggest one. Substance misuse, really good. Dementia is an interesting one. So often it usually goes the other way around, where in an older person, they are thought to have dementia, whereas actually they're depressed, which is where you hear the phrase depressive pseudo-dementia. But if it's a really long history, changes in personality and something like that, yeah, it could be something like frontotemporal dementia. But depression is often missed in older people, and because it can cause things like concentration difficulties or changes in your memory, then it can sort of mimic dementia. Something which I think is really, really useful is there is a trend in older patients where it helps differentiate, is this depression or is this dementia? Because it can be quite hard sometimes. The idea is, if you ask somebody with dementia a question which they don't know the answer to, they are more likely to try to come up with an answer. Whereas with depression, because it saps you of energy, sort of mental reserve, a lot of the time patients with depression will respond to many questions with, "I'm sorry, I don't know." Whereas in something like Alzheimer's disease, where you might ask them, for example, think of a common adage, idiom, that sort of thing, and you ask them, what does it mean when we say don't beat around the bush? And what might happen is that the patient with Alzheimer's disease will start talking about a bush and a person hitting the bush. It does happen. If you're on old age psychiatry, for example, or when you're on care of the elderly, you might be able to elicit this. If a patient has pretty good going dementia or delirium, they will try to explain idioms and things like that. Whereas a person with depression might just say, "I'm sorry, I don't know." Or even if it's just life events like, "So how long have you been doing this for?" And they might get it completely wrong, say, "I've been married for 20 something years," and their daughter's there saying, "No, they've been married for 50. Whereas somebody with depression might just say, "Don't know, sorry." So those differentials are really important. Even things like hypoactive delirium, but that's got a much, much shorter history. So let's talk about treatment. Well, the medication is obviously the most relevant bit for us as medical students, but we'll talk a bit about psychological therapies because they do come up in SBAs, and it's still useful to obviously know about them. So once you have a patient and you've diagnosed them with depression, there are generally a few things you should always do. One of them is assessing risk of suicide, a really, really important thing that I have to say, and all of you, I hope, will take away from this, all of you probably already know about, is that when you are assessing risk of suicide, you have to be direct. You can't beat about the bush. You can't sort of hint at it. You have to, there are obviously tactful ways of doing it. The one that I like to use is, sometimes people who've been, in the position you're in or feeling the way that you are at the moment, sometimes have thoughts that life isn't worth living or think about taking their own life. Have you had any of those thoughts? So obviously you don't come straight out with, "Have you thought about killing yourself?" But you can do it tactfully, but in a way which is still direct and asking the question head on, because that's something you do not want to miss, and it can surprise you sometimes. Sometimes you might be talking to a patient on a cardiology ward and they might just drop it on you that, "You know what, I just don't want to be alive anymore." So it's really, really important to get that head on. Another thing that's really important is, well, I'll ask you this. What's something you might want to assess if your patient who you think is depressed is a single father of 3 children at home? What do you want to know? Safeguarding, perfect. And when we say safeguarding, we don't mean, "Oh my God, take the children away," but it's, how are you coping? Do you need any help at home? And obviously beyond that, then if it gets to more worrying levels, do the children need to be temporarily taken into care, things like that? Because sometimes you'll hear fairly horrifying stories of things like young children having seen their parents self-harm or attempt to take their life, which is obviously incredibly traumatic. Often it's more the lower end, which is there's the person who is depressed, and on top of that, they're having to juggle lots of stuff at home. And if they've got people who are dependent on them, then it becomes even more of a load, and you need to assess sort of, is there anything we can support them with? So safeguarding is really, really important. Right. Once you've assessed for those, we can start thinking about treatment. NICE's algorithm starts with low intensity psychological therapies. So with low intensity psychological therapies, we're talking about things like guided self-help, which is a bit rubbish. They will give it, it's sort of, here are some sort of worksheets to go through or some information things to read. I don't honestly know if that helps people, but they do it. It's cost effective, I suppose, which is a really important thing in the NHS. Then you have counselling. Counselling is effective for some people. It's essentially you talking to somebody. It's not so much them being there to give you ideas or to give you solutions, but it's more the benefit of just talking to somebody. You've also got things like computerized CBT, group-based CBT, or sometimes what is quite common nowadays is prescribing activities, like telling people, right, I'm going to refer you to a structured physical health program, or I want you to go outside for a walk 3 days a week, or something like that. Once we start thinking of more moderate, severe depression, we start thinking of higher intensity psychological therapy. So these are patients who are being seen once a week. What is the problem with higher intensity psychological therapies? I don't mean with them themselves, I mean in terms of referrals and stuff like that. Insane waiting lists. Like Anya said, we do not have enough clinical psychologists, trained psychotherapists. In some parts of the country, you can be waiting for up to 18 months to 2 years in order to be seen, in order to start therapy on the NHS, which is a really, really big problem. Often people will have been over their episode, that current depressive episode, by the time they get called up and say, hey, it's time for you to have your appointment. Okay, lots of different types of therapy that can be given. You've got things like interpersonal therapy. Classically, in an SBA, what sort of person might be given interpersonal therapy? And I don't know why I said that, because I don't think interpersonal therapy will ever be the right answer in an SBA, but based on the name, who do you think gets interpersonal therapy? So with interpersonal therapy, the premise of it is there's this idea that depression can be caused by difficult relationships and difficult interactions. So it tends to be given to people who, it doesn't necessarily have to be romantic relationships, any sort of with your parents, with friends, things like that. People who struggle with those tend to get IPT. It's not a very common therapy. You won't see it around a lot, but it tends to crop up as an option in SBAs. Cognitive behavioral therapy, I won't ask you about this one, but the premise, if you break it down to the names, people get given it because they have cognitive distortions. In depression, you have cognitive distortions like I am worthless, I'm a liability to my family and friends, I bring other people down, I'm no good at anything. The idea is identifying those, and stage 2 is the behavioral bit, which is let us come up with behaviors that help you deal with these cognitive distortions. Go away, phone. So the idea being, for example, you think that you are worthless. Well, now let's come up with an activity that every time you identify that thought, you tell yourself, no, you're not, and you go and do something that is worthwhile, for example. That's a poor example, but that's the general premise of it. The other option is psychodynamic therapy. Psychodynamic therapy is if you consider CBT to be concerned with the now, I am having a problem now, I need quick solutions, immediate solutions I can apply now. Psychodynamic is more concerned with the past. People who seem to be having repeated depressive episodes and they can't really figure out why. And it's sort of trying to unpack the past and see, is there anything that we can identify that might be causing these recurrent episodes or for you to feel the way you feel. The other non-antidepressant option is electroconvulsive therapy. When do we use electroconvulsive therapy? What are the indications for it? Yeah, so severe treatment-resistant depression is one of them. Catatonia, good. And the other one is severe or treatment-resistant mania. So it's for the affective stuff. Severe treatment-resistant depression, severe mania, and also catatonia. Catatonia is the one true psychiatric emergency. That is the sort of thing that a consultant practically the only time that a consultant psychiatrist will be called in the middle of the night to come in. It is dermatology's equivalent of toxic epidermal necrosis or Stephen-Johnson syndrome. It is, or erythroderma. It's a proper psychiatric emergency. People can die from it. That's the one that needs ECT. Bear in mind, people can have ECT electively. So sometimes in people with severe depression who still have capacity, you can say, look, an option's ECT, and they might say, actually, yes, I'd like that. It's a extremely misunderstood condition, treatment, mainly due to how it's been represented in media from the 60s, 70s, 80s. I don't know if anybody's gotten to see it during their psych placement, but essentially all it involves is the anaesthetist gives propofol. There's always an anaesthetist there, so the patient is temporarily under general anesthetic. They're also given a muscle relaxant, so usually something like succinylthonium or rocuronium. And then you apply electrodes, usually bilateral, but you can do unilateral if you're worried about side effects, and you just induce a tonic-clonic seizure. You literally select a dose, except the dose is electricity, so it's in millicoulombs even, and you tonic-clonic seizure, you monitor their EEG, and then 5 minutes later in the recovery bay, they come around, you give them tea or coffee or a biscuit, and then 20-30 minutes after they first came in, they're back out. It has its side effects, as with anything, most common being headache, muscle aches, because as for the tonic-clonic seizure, the tonic bit is everything contracts at the same time, which is why we give them a muscle relaxant so that they don't break anything. And the more worrying one is memory loss. Usually that's short-term, but in some people, they report longer-term memory loss. The whole thing with ECT is very, very controversial. Also, we've got no idea why it works. But the weird thing is it's incredibly effective. And the way I'd like you to consider it is it creates a window for you to start treatments that the patient is too unwell to have them work effectively. So intensely treat them with antidepressants or therapy. Because if somebody's catatonic, they're not going to respond to therapy. But ECT creates this window where they are sort of better after that. So last 10 minutes, we are going to talk about antidepressants. Antidepressants obviously being a huge part of psychiatry and also a huge part of anywhere you're working, because so many of your patients, our patients in the future, are going to be on them. They're an incredibly common medication. So what is our first line group of antidepressants? We'll start with a straightforward question. And once somebody has answered that, somebody tell me, why are they our first line? Why are these medications our first line? Thank you. SSRIs, selective serotonin reuptake inhibitors. Why are they first line? Why do we like SSRIs so much? It was often a really good question to think with any medication. Why is this first line? Yep, there we go. Side effect profile is generally more acceptable than other classes of antidepressants like the tricyclics. Additionally, they're incredibly safe in overdose. There are you can maybe count on your hands the instances of pure SSRI lethal overdose. I think they had to look for ages to find an instance of somebody who had managed to die by overdosing on citalopram, and the amount they took was horrific. A lot of it was in liquid form as well, because there's no way you're going to be taking that many tablets. In the words of one GP I met, if you take that, if you take all your pills, you're far more likely to be sad than dead. So don't overdose on SSRIs. They are that safe in overdose. Obviously, once you start throwing in other things like benzos and alcohol and stuff like that, those are the things that are more likely to kill you rather than the SSRIs. We don't really know why they work. People 40 years ago or so believed in the sort of monoamine theory of depression, which is that serotonin depletion leads to depression, which is why SSRIs work. They bring your serotonin levels up. That theory has had no evidence to support it. So nowadays, we think it's far more likely that it's a downstream process that serotonin modulates, and that depression is, we know that depression is not usually serotonin. let's talk about choice of SSRI. So technically, you could start with anyone you want. I've seen people who start with fluoxetine, so that's Prozac, which is incidentally, I think, the most commonly prescribed medication in the US, or at least first or second. But often most people start with sertraline or citalopram. The good thing about sertraline is it has very few interactions with other medications. This is why sertraline is basically your first choice SSRI in people with lots of physical health conditions. You might have seen on PassMed, there's this question saying this patient's just had a heart attack, what antidepressant should you use? Sertraline's first line in that case. That's the one who's like, oh, cool, I have a reason to prescribe that one. There are some SSRIs you should not prescribe with certain conditions. So let's say if I was taking clarithromycin long-term, for whatever reason, what SSRI should I not have? What SSRI should not be prescribed for me? Thinking of one of the side effects of clarithromycin. That's the link here. Yay, perfect, citalopram. So citalopram and escitalopram, which are very, very similar, very few different. By the way, if you're wondering about the different SSRIs, the reasoning why there's so many of them is each company, one of the big pharma companies, so GSK, Pfizer, the ones who are making the vaccine now, made their own SSRI, patented it, and called it a different thing. They are slightly different in structure, but that's about it. So fluoxetine, I think, is GSK's SSRI and so on. Obviously, the patents have all gone, so you can get them in generic form now. But that's why you've got citalopram and escitalopram. Different companies made them, patented them. The differences are so small. But the weird thing is people respond to different SSRIs differently. Some people have no response to sertraline, but then do fantastically on citalopram, and we don't really know why that is. So citalopram and escitalopram are associated with elongation of the QT interval, so not a good idea in people with long QT syndrome or taking any other medication which predisposes you to that, such as your macrolide antibiotics. Let's talk about side effects of SSRIs. What side effects come with SSRIs? So we're often usually told they've got a good side effect profile, but they still do have a fairly high discontinuation rate. And patients will stop them because of side effects. What side effects can they have, or do they have? And there are a lot of them. So a GI bleed would be really unfortunate, but yes, they are associated with gastritis and they can lead to GI bleed, which is why it's thought that it's a good idea to co-prescribe them with a PPI, but I've never ever seen that in, let's say, young people our age. I've seen it in older people. If you're really unlucky, yeah, it can increase, you can get a GI bleed from something like sertraline, but oh my God, you've got to be unlucky for that. Hyponatremia is a really good one. Always in confusion, an elderly person, you look and they're on citalopram or something. Yeah, hyponatremia is a big one. Increased risk of suicidality initially, very, very important. So technically what you're supposed to do after you start somebody on antidepressant is to monitor them and to have a review appointment in 2 weeks. This is for primary care. However, if they are under, I think it's under 25 or it might be under 30, basically around our age, you review them in a week. The reason for that is initially they are thought to cause an increased risk of suicidal ideation. Again, we don't really know why. I remember in 30 or something to do with changes in receptor transcription, something like that, but we don't know why. The thing is, you obviously don't want to miss it, which is why review in a week if they're under, let's say under 30, to be reasonable. If you've just started an antidepressant, 2 weeks for anybody else. So increased risk of suicidal ideation, hyponatremia ones, which are really good because I haven't put them there. So the really common ones are GI symptoms, people that complain of sort of brain fog. Talvinda, I don't know if you had Talvinda when you were in second year doing your farm. We had Talvinda Sierra doing farm for us in second year for at least the psych stuff. Said no anticholinergic symptoms. Absolute lie. Lots of anticholinergic symptoms. Dry mouth, sort of constipation, maybe feeling nauseous, that sort of thing. Actually quite common with some antidepressants. And, like we said earlier, sexual dysfunction, associated with sexual dysfunction in both women and men, so anorgasmia, decreased libido. So that's really important to check for as well. You know, you don't want a person to be feeling better mentally, but now their sex life is causing a problem for them. And then there's this idea that technically you should withhold SSRIs in the first trimester of pregnancy. But if you've got somebody who's finally found the right medication for herself, and previously had very severe episodes where she's had to be admitted under the Mental Health Act, you're not going to stop her SSRI because the risk of stopping it far outweighs the potential risk to the baby. Right, moving on to other ones. So you've got things like venlafaxine, that's an SNRI, so serotonin and noradrenaline reuptake inhibitor. Often used as a third line. Remember, SSRIs are often used as second line, sometimes third line. It's usually SSRI 1 doesn't work. Now we're going to SSRI 2, maybe SSRI 3 before we start thinking about something else. So venlafaxine is an SNRI. Mirtazapine is a weird antidepressant, which is quite useful in certain populations. Does anybody know who mirtazapine is quite good for? The elderly, perfect. We like to use mirtazapine in the elderly for two reasons. People who are older with depression tend to be more vulnerable to insomnia, or at least poor sleep, and for loss of appetite and weight loss. Mirtazapine has the opposite as two of its side effects. It causes weight gain, usually through an increased appetite, and it's quite sedating. So it's actually quite good for those patients. It also seems to have less anticholinergic burden, which when you're doing care of the elderly, geriatrics, you'll find is a very, very big thing in care of the elderly because anticholinergic function will increase your risk of cognitive dysfunction, falls, that sort of thing. Tricyclics. Tricyclic antidepressants, so your things like amitriptyline, imipramine, and so on, clomipramine, are actually more efficacious than SSRIs. There's evidence to suggest that they are better than SSRIs in terms of actually dealing with the depression. Problem is, as somebody mentioned earlier, they are very, very dangerous in overdose. In fact, it's the most overdose on antidepressant in terms of people who've died after overdose. They are lethal, and people can end up in ITU on them if they haven't died. They're also very dirty drugs, so you can kind of explain the side effects through the receptors they bind to. So does anybody know what the common side effects of TCAs are? The good thing with these is that they're easier to remember because you can bind them to the receptor. Perfect. So dry mouth, constipation, blurred vision, blurred vision are all anticholinergic side effects, and the tricyclics have a high affinity for the muscarinic acetylcholine receptor, so they are strongly anticholinergic. Weight gain, you can put on a lot of weight on amitriptyline or related medications. They can cause a lot of weight gain. Do bear in mind that though they are more commonly used for neuropathic pain nowadays, the doses used for depression are much higher. So somebody on with neuropathic pain might be taking 10 milligrams of amitriptyline. The effective dose for depression starts at about 75. It's a really big difference for depression. So the side effects are much more intense. You'd rarely see people complaining about that sort of thing if they're taking it for neuropathic pain, because you're taking it about 10, maybe 20 milligrams. 75 upwards for depression, side effects are a lot more noticeable. Alpha-1 adrenergic receptors are bound to. That causes your postural hypertension, also has got some cognitive effects. And your histamine 1 receptors are bound to, which make them very sedating medications. Really sedating medications. So that's the problem with tricyclics. Let me ask you this question. Why, well, tricyclic overdose, what is the mechanism of death? How does tricyclic overdose kill a person generally? I will proceed then, I guess, since I don't want to keep you guys for much longer. So the thing with tricyclics is they are incredibly cardiotoxic. The method of death is usually an arrhythmia. You might be wondering why that is. Venlafaxine is similar as well. Venlafaxine is also cardiotoxic. The two things they have in common is both of them are reuptake blockers for noradrenaline. Remember, noradrenaline massively increases your sympathetic drive, including to the heart. If you massively block the reuptake of noradrenaline and noradrenaline levels start building up, that's not good for the heart. You will go into an insane tachycardia, which inevitably breaks down into an arrhythmia, which inevitably turns into a ventricular arrhythmia, and that's what kills people. They are very cardiotoxic in overdose. One other one to mention, so you've got your monoamine oxidase inhibitors. These are really rare. If you guys remember in second year, they talked about the cheese reaction, which is the idea that people who are taking monoamine oxidase inhibitors would eat something like cheese or wine, and then their blood pressure would spike, and they'd have a hypertensive crisis. And the reason for that is the monoamines, so that's your dopamine, noradrenaline, serotonin, are all derivatives of the amino acid tyramine, which is common in dairy and also wine. Obviously, these are broken down by monoamine oxidase. You block that enzyme. People take in tyramine-rich foods, and their noradrenaline levels go up, and serotonin levels go up. Remember, serotonin is a vasoconstrictor peripherally. Dopamine also has a similar function, so people get really hypertensive. Evidence suggests that was a bit overkill, and the risk was overestimated, and the problem then was that they were irreversible. There are newer drugs which are reversible. You won't see a lot of them, but they might be making a comeback, because there's also evidence to suggest that the MAOIs are also more efficacious than SSRIs. Couple of things to remember about antidepressants, a couple of which I just remembered now, so I will add them to the slides. First one, patient becomes manic or hypomanic, stop the antidepressant straight away. In the same way like anaphylaxis, due to penicillin, stop the drip. Manic, stop the antidepressant. Also, patients should remain on an antidepressant after an improvement for at least 6 months. They shouldn't come off them quicker because there's a high risk of relapse. So those are the two main things with antidepressants. Don't come off them. Really tell the patient, please don't stop this on your own, because antidepressant withdrawal is a thing, especially with the SSRIs. You do not want them to cut it suddenly. Most antidepressants need to be tapered down. Fluoxetine is a bit of an exception. Does anybody know why fluoxetine you don't need to worry too much about bringing the dose down slowly? And this is actually quite a useful thing to know, because it does differ from the other SSRIs notably in this aspect. Not necessarily less withdrawal effects, but less withdrawal effects because almost you've got the right path but the opposite direction partially. So fluoxetine's got a very, very long half-life, which means that if you stop it, it kind of eases its way out of the body over time. Whereas something like citalopram, which has got a half-life of I think like 12 hours, you stop it and their levels drop really quickly. Fluoxetine's got an insanely long half-life. I think it's something like 17 days. So its levels will gradually drop down. Ideally, you should still be careful with it, but it's not as worrying as a patient suddenly stopping their citalopram, for example. Right, we started with an SPA. In the last few minutes, we will finish with an SPA. So, 32-year-old man, he's brought into ED, he's unconscious, and his girlfriend is very, very distressed. She's brought him in. He passed out. His friend gave him something at a party. After that, he passed out. You examine him. He's still unconscious. His pupils are dilated. You can elicit clonus and hyperreflexia on his lower limbs. And on OBS, he's tachy, he's hypothermic, and he's very, very sweaty. The wife mentions that he takes sertraline. She's brought the blister back, and you see that he's taken 200 milligrams. What substance did he most likely take at the party? So I'll give you about 10, 20 seconds to have a look at that. And then I will just ask what substance he took and see what somebody says, and we'll quickly go through the right answers. In the meantime, if somebody's done, what can someone tell me about a 200 milligram dose of sertraline? Big, small, in the middle? So 200 milligrams of sertraline is the maximum dose. So that's a big dose of sertraline. Sertraline starts at 50 and it goes up in increments of 50. So you can go up I'm pretty sure it's the maximum dose, but I will double check in case I'm wrong. You can go up from 50 to 100 to 150 to 200. 200 is the biggest dose of sertraline you can get. Right, what would anybody like to give me what they think the right answer is? I only need one person to say it, and then I'll move on. But what do you think the most likely substance that he has taken at the party is? I like this question because drug interactions, and I like pharmacology, as I've said a lot of times, I think. Just one person. I just want one person to tell me what they think. Is it meth? Is it cocaine? Did they take heroin? Did they have cannabis? Or was it MDMA? Meth is a good shout. Meth is a good shout, but it's not the most likely substance. Yeah, MDMA. Okay, let's talk this through. So, cocaine. How does cocaine work? It is a inhibitor of the reuptake transporters for dopamine and noradrenaline. What's it a problem with? So what does it do? Big flare up of the sympathetic nervous system. So they get their dilated pupils, which is why those two are kind of red herrings. Dilated pupils, tachycardia, and hypothermia, as well, all of your sympathetic symptoms are very much associated with your sympathomimetic drugs. So that's cocaine and methamphetamine. Cocaine, instead of blocking the reuptake, it just blocks the vesicular transporters. So instead of dopamine and noradrenaline being go into the vesicles, it just can't, and it diffuses into the synapse. Cannabis, not so much. Doesn't particularly interact with a lot of things, and heroin is a big depressant, so you don't tend to get tachy and stuff like that. What does this patient have? What are we getting at here? MDMA and sertraline, what do they have? In the meantime, I can completely see why anyone would have gone for meth or cocaine, because the signs very much represent cocaine or methamphetamine toxicity. But what's more likely here is, because he's got the sertraline, is what Alice says, this is serotonin syndrome. Important thing, any antidepressant can cause serotonin syndrome. If you give a tiny person a very big dose of antidepressant, you can give them serotonin syndrome. If you give somebody 2 antidepressants, you can give them serotonin syndrome. If somebody who's on an antidepressant takes another medication which increases serotonin syndrome, this includes both prescribed drugs and illicit drugs. So MDMA, LSD, both increase levels of serotonin. MDMA blocks serotonin reuptake, a bit like an SSRI actually. So take an SSRI plus MDMA, your serotonin levels shoot up. Other medications, so medications we prescribe, triptans are actually serotonin agonists, so they'll do the same job as serotonin, which is why they can be a bit of a problem. So, how is big malignant medication induced lethal condition? Because both of them will present with sympathetic overdrive, so your tachycardia, your dilated pupils, your hypothermia. But there's something that neuroleptic malignant syndrome has, which serotonin doesn't. Serotonin syndrome doesn't tend to have. And also there's a difference in the time pattern as well, but I'll say that. The distinguishing feature So the thing to remember with antipsychotics is they're perfect. Yes, muscle rigidity. Antipsychotics are all they have in common is they are dopamine 2 receptor antagonists. As a result, they will mess with your direct pathway in your basal ganglia, and they will cause Parkinsonian symptoms, including rigidity. Patients who have neuroleptic syndrome will be very, very rigid. If you have a patient with very, very rigid contracted muscles, what blood test might be elevated, or often is elevated in these patients? CK, perfect. If you suspect an MS, do a CK. CK will shoot up in neuroleptic malignant syndrome because they're so tightly contracted, they will break down their muscle, and creatine kinase will just flow into the blood. So you have sort of your cognitive symptoms, which is the patient can be behaviorally different, confused, agitated. Autonomic, because serotonin can also lead to sort of collateral noradrenergic activation. it's sort of a negative feedback presynaptic thing in that presynaptically serotonin release will cause noradrenaline release onto the postsynaptic neuron. Also, serotonin's prokinetic in the GI tract, so they'll get diarrhea as well, which is not a sympathetic symptom. Usually constipation is. And also they'll get these weird somatic neurological ones like hyperreflexia, myoclonus, and they'll get a tremor. Lots precipitate it. Tramadol's an important one. People get put on tramadol for pain, and then they get neuroleptic malignancy. They get serotonin syndrome because they are also on sertraline. So be careful of tramadol. Some of the anti-epileptics, like mood stabilizers, valproate, they can cause it too. There's a whole list of drugs. Generally, be very careful. You differentiate for NMS, not MNS, by rigidity, Parkinsonian symptoms. Also, NMS tends to come on about a week after you've started the antipsychotic. Serotonin syndrome is very quick, very quick. This is why if a person takes a drug at a party or something, they will go into serotonin syndrome very quickly. Important thing, stop the drug. Give a 5-HT antagonist if it's available. So, lots of places have cyproheptadine, but if you're in a smaller DGH, it might not. And then it's just supportive care. Bring their blood pressure down, cool them down. Sometimes they'll need ICU until they get better. Right, that overran by quite a bit. Really sorry about that. But I'm going to stick around for questions. I'm really sorry we didn't get to do bipolar disorder as well. I'm going to edit these slides because what was mentioned at the start of the session, and I am incorrect. So a 5.2, you can't use a 5.2 in A&E. I was wrong about that, and I will change that, and I will also mention what you can do with a patient A&E. Thank you for pointing that out, to whoever pointed that out for me, because otherwise I'd have been giving you guys the wrong thing, and I'm really sorry about that. So A&E department, according to the document, usually if a patient's brought to A&E by the police, it will be their section 136 or 135 that's holding them there. But I don't know what you do with a patient who's trying to leave A&E due to, when they have a cause that they should stay for. So I will get back to you on that one. I am going to upload the feedback thing onto the Facebook post because I don't have the link for it now. But I'd be really, really grateful if you could fill that in. It really helps me make things better, and obviously I want the things to be obviously most useful for you guys. So any feedback you give will go into making these sessions more useful. So I hope that was useful. As I said, I'll stick around for questions, and yeah, thanks for coming along, and I hope you have a good rest of Monday and rest of week. No worries, guys. Yeah, I'll stick around for a bit. Indication for stopping antidepressants, if the patient's feeling better. Basically, once the patient's feeling better, you wait for 6 months. They have to stay on the antidepressant, the same dose for 6 months, and then you can start bringing it down. The other indication for stopping an antidepressant is if they start developing serotonin syndrome or if they become manic or hypomanic. So if they start swinging the other direction and they start getting quite high mood, so disinhibited, lots of energy, that sort of thing. The stuff we'll cover in the bipolar session. But those three, if they're getting better, you don't need to keep them on it, unless it's something like recurrent depression where they've had 5 episodes, and each time they stop the antidepressant, they get worse. So there are some instances where a person stays on antidepressants long term, but generally, if they get better, stop it after 6 months from them getting better. If they're manic, stop it, and if they're having serotonin syndrome, stop it. No worries. No worries. Oh yeah, sure thing. I think, yeah, you can use a section 4 in ED. Okay, that would make sense. I'll post that on the thing then. Because I've never seen a section 4 used before, and I've always thought it was a sort of thing where if a GP is really struggling to keep a patient they can use a section 4, but that would actually make sense. Yeah, that would make sense, fair. And then the point, thanks for that. And thanks for pointing out the whole thing about the 5-2. Otherwise, I totally wouldn't have known. I really appreciate that. The point about sertraline and heart attacks, basically sertraline compared to other SSRIs has got the fewest interactions with other things. So it's actually really good for patients with lots of chronic conditions. So, for example, your patients had an MI and now they are depressed, which is really common post-MI. Up to 50% of patients will develop depression. Makes sense. It's a really stressful thing and it really impacts the quality of life. Sertraline is actually your first choice in somebody with a history of cardiovascular events. Just generally any chronic long-term condition, sertraline's good. It doesn't really interact with other medications. So that's a link with MIs. It's good for people who have a cardiovascular history because it doesn't interact with lots of medications they're on, which makes it just generally good in chronic things. I think the main reason I used heart attack specifically is there is a pass med question which people might come across where it goes, this person's had an MI, now he has depression, what should you start him on? Because to nice, if they have that, sertraline is the first line for someone with chronic or long-term or significant physical health conditions. No worries, Vanessa. Thanks for coming along. I think I'll stop recording at this point.